Our next speaker's topic is recognizing and managing child maltreatment. Dr. Joan Elizabeth Shook is professor of pediatrics in the Pediatric Emergency Medicine section at Baylor College of Medicine. As head of the section for 22 years, she was director of the emergency department and the first director of Baylor's Pediatric Emergency Medicine Fellowship. In 2012, she joined Texas Children's Hospital and Integrated Delivery System as Chief Safety Officer and Chief Clinical Information Officer. She is also an adjunct professor in administrative science at Rice University. Please welcome Dr. Shook.
It is for me to be here with all of you. All of us like working the good fight, right? Pediatricians doing the right thing. And following Dan Gross, I have to tell you, is a little bit amazing because of all the fabulous work that they've done. What I'm here to talk about today is a topic that's important to all of us and to all of our patients and families. Child abuse, or more precisely, how to recognize high-risk families and how to prevent children from having further problems. Let's see here. Whoop. Yep. There we go. First, it's important for you to understand who we are at Texas Children's Hospital. We're an integrated system of pediatric healthcare providers, from primary care pediatricians to outpatient clinics, urgent care centers, diagnostic centers, hospital-based services, and complex outpatient care. We have a health plan, we have maternity services. All of this exists under our umbrella because we, like you, are committed to providing excellent care for our patients and their families. Now, I can hear you thinking, Texans love to brag. Is she just bragging up there? Well, that's not really the point. What I want to make sure you understand is that we have every resource to do things well, and that sometimes we aren't doing things as well as we should. I want to start with a story. Every pediatric emergency physician has a story like this, and I want to talk to you about Daniel. Excuse me. Excuse me. Daniel was a 13-day-old boy when he was referred to the emergency department by one of our community colleagues for the evaluation of ecchymoses on his buttocks. There was no known trauma. He was feeding and behaving normally. Were very nice people, and that they had a good support system. As is typical in our system, because it's complicated, a CPS referral was not done by the primary care provider, but sort of deferred to the emergency department. The physical exam was normal except for the bruising. And this is what his buttocks look like. A second view of that same little behind is on the next slide. So Daniel was evaluated in the emergency department, and of course, concern was raised for child abuse. And I know that's what you were thinking too. We consulted child abuse pediatrics. I told you we have every resource available to us. We had social service come and evaluate them, and our Children's Protective Services, which is our state agency, also came. We performed the recommended workup, including a skeletal survey, a CT scan of the head, and blood work, and all of those studies were normal. But because of the nature of his injury and the age of the baby, he was placed with his grandmother pending the outcome of a complete CPS investigation. The father, when he got a detailed interview by CPS and social service, remembered that he'd been holding Daniel down during his newborn screen. He said that he'd been wearing his black diamond watch, and he was a basketball player by background, and said that he sometimes didn't really know his own strength. So of course we investigated that black diamond watch, which is illustrated here on the screen, and then we quickly took a look again at his little boy's bottom. We took measurements of that watch and of the bruising and decided that the watch was likely the cause of the bruising, and we informed Children's Protective Services of our findings. So I think pretty understandably, the case was closed by Children's Protective Services, and our internal CPS team also closed their case, and Daniel was returned to his parents. He was seen frequently by his primary care provider for a variety of complaints, including unexplained bruising on his chest and fussiness that was also unexplained. The community pediatrician was not in contact with CPS nor with the team at the hospital, and the hospital team was not in ongoing contact with the community care provider. At 3 months of life, Daniel presented to the emergency department after having fallen from a recliner onto a carpeted floor. The story that was that he'd fallen asleep on his dad's lap after a feed, and the dad had fallen asleep also, and then the baby apparently rolled off the dad's lap onto the floor. Workup at that time showed bilateral retinal hemorrhages, acute on chronic subdural hematomas, and healing rib fractures, 7, 8, and 9 on the left. We felt terrible, of course. This is a CT scan. You can see pretty clearly the acute on chronic subdurals in this little person. And you can also see on this next film his 3 rib fractures. We failed this baby. There's no question about it. And with every resource available to us, we still didn't protect him the way we should have. He was hurt several times in the 2-month interval between his first and second visits in the emergency department. I think part of my introduction said, maybe it didn't. It's very hard for me to listen to those introductions. One of my current jobs is I am the safety officer for Texas Children's Hospital Integrated Delivery System. In that role, one of the things we do all the time is look at events in detail that didn't go well. And then we try and learn what we have to do better the next time to prevent the same outcome from occurring. We call that a debrief. And so let's now debrief Daniel. We know all of these statistics, all of us in this room know this, that Children's Protective Services investigates more than 2 million cases of child abuse a year, and a quarter of those come from primary care settings. 686,000 children are confirmed as victims of child abuse every year, and about 1,600 kids died as a result of their abuse. And we miss child abuse in all practice settings where children seek care. There are 5 major areas where things typically go wrong. We delay in making the diagnosis of child abuse by a faulty history taking, by accepting diagnoses from imaging studies that are not read correctly because of poor understanding of child imaging findings. That wasn't really a problem in Daniel's case, but it is a common problem. By not really understanding what we're seeing, by failing to adhere to best practices and guidelines, and then failing to report when we should. Let's go through these one by one. First of all, the history. You all know this. You remember it from medical school. This is asking the right questions and understanding what we hear in the context of what we see. It's the cornerstone of what we do, and honestly, it's what kind of separates us from all the computer algorithms that have become so popular. In Daniel's case, he was seen for bruising and fussiness without explanation between his first ED visit and his second one. But we, pediatricians in my system, failed to understand what we were seeing. That's a miss. What we were seeing was a sentinel injury, which is a visible minor injury that's poorly explained and concerning for physical abuse. And that is any bruising on the torso, ear, or neck for a child less than 4 years of life, and any bruising at all or intraoral lesions in an infant less than 4 months of life. The history of a sentinel injury should increase your level of concern for child maltreatment, and identification and reporting of these injuries can prevent further abuse. The injuries are a little bit different in their appearance and in their location than those that are related to bleeding disorders. In children with inflicted injuries, remember that head, neck, and torso. In children with bleeding disorders, it's upper arms, inner thighs, and feet. And pre-mobile babies simply do not get bruised. Now, the presence of a sentinel injury means that the baby is at increased risk for abuse. This group of hospital-based researchers looked at a group of definitely abused children less than 12 months of life and found that 27% of them, nearly a third, had had a sentinel injury documented before the diagnosis of child abuse was made. That compares to only 8% of intermediate risk babies and 0% of low risk babies. I think we can conclude that the detection of a sentinel injury could have prevented many cases of child abuse. Another group of researchers looked at bruising in infants less than 6 months of life who were being evaluated for abuse. Slightly different population of infants, but an important one. And found that in that group, there were a subgroup of 147 babies who presented with apparently isolated bruising, like Daniel, isolated bruising. Almost 60% of that subgroup had serious injuries, including positive skeletal surveys in 34 children, positive CT scans in 40 children, and significant abdominal injury in 4 babies. Unexplained bruising in an infant is an extremely high-risk finding. I also want to direct you to a study that's coming out in pediatrics this month, November, that looks at the Pediatric Health Information System, the FIS database, and really gives even more dramatic conclusions than here. This group of researchers under Harper's leadership then went on to look further to see whether bruising was in fact a reflection of a bleeding disorder. I suspect I'm not the only pediatrician in the room who's been a witness in a child abuse trial and has been grilled by the attorney for the family about the baby's clotting studies. Honestly, I find that a little uncomfortable. Clotting studies are not my area of expertise. But very importantly, this group of researchers found that there were no bleeding disorders in this large group of babies. Abuse is common with isolated bruising. Bleeding disorders are not. I want to do a quick parenthetical comment about the dating of bruising, since I've been grilled by lawyers about this also, as in the following statement. Maybe you've heard a little bit about this too. Don't you know, doctor, that when the bruises that you saw were properly dated by our expert, it was obvious that they occurred when my client wasn't even in the home? And then when I'm on that witness stand, I'm thinking, oh my gosh, what did I miss here? But a Cochrane review looked at all the available literature and concluded that bruises cannot be dated with accuracy, and further that bruising in infants who are non-mobile, the injury is most likely abusive in origin. So far our debrief has found gaps in both history and understanding signs and symptoms, and both of these contributed to the delay in Daniel's diagnosis and into his ongoing abuse. Let's move forward to guidelines. The AAP Committee on Child Abuse and Neglect published the evaluation of suspected child physical abuse this year in pediatrics. If you haven't read it, I really recommend that you do. It provides a thoughtful and comprehensive guideline for the identification and management of child abuse. We missed the mark on an item that I've listed on this slide. Bruises or other skin injuries in non-ambulatory infants, oral injuries in non-ambulatory infants, or injuries not consistent with the history should prompt a skeletal survey. When Daniel presented to the PCP with unexplained bruising, he may have had the fractures already and maybe not head trauma and might not have gone on to his significant injuries. We missed the opportunity to repeat a skeletal survey, and maybe we should have reported him to Child Protective Services again. Let's ask ourselves how well we do that reporting. We all know that we have a duty to report, right? All states in the United States have mandatory reporting laws. The details vary, but the reporting duty remains. And sometimes we fall down in that duty. And I guess the question is, why is that? The answer is really complicated. There were 434 primary care pediatricians from the CARES Research Network who participated in a child abuse reporting study. They were asked to collect data on child injury visits, which included the nature of the injury, the nature of the child, the nature of the family, and the likelihood that the injury was caused by abuse. Child abuse was suspected in 1,683 cases. Child abuse was reported in only 95 cases, which means that in 1,588 cases, it was suspected but not reported. Cases are less likely to be reported if the practitioner thought that the injury was possibly, as opposed to likely, caused by child abuse. Pretty subjective. It was also, reporting was increased if the injury was not a laceration, if the child had severe injury, or if the child had more than one social risk factor or was new to the practice. Clinicians' prior experience with child abuse reporting also influenced their decision to report. Of course, we're human, and sometimes working with CPS and law enforcement is time-consuming and pretty unpleasant. We need to figure this out. This is a great opportunity for ongoing advocacy. A subset of the CARES providers were looked at in greater depth regarding their reporting behaviors. And one of the things they said was that an alternate management strategy was invoked if we didn't report. Those are most frequently increased follow-up with the PCP and heightened awareness of the possibility of abuse. Those things occurred with Daniel and didn't really help him. It's understandable why we make these conclusions, but it's very concerning. Because we know that delaying in reporting can impact the child since abuse can be ongoing, and not only ongoing with Daniel, but with this group of 77 kids who were diagnosed with healing abusive fractures. Nearly half of them had had visits with the provider prior to the diagnosis of healing abusive fracture, and at least a third of them had a missed opportunity to diagnose child abuse when they presented with unexplained bruising and swelling. This study looked at a larger group of children up to 3 years of age with abusive fractures and again found missed opportunities. Little boys who present to the general emergency department or the primary care provider with an extremity fracture are at particular risk. It's not done purposefully, of course. We're all thinking all the time. But putting the pieces of the history and physical together is sometimes difficult, and sometimes we don't see what we really should. In this seminal paper by Carol Jenny, she showed just how hard we work to make sense of what we see and sometimes miss what's right in front of us. She reviewed 173 children with abusive head trauma and found that nearly a third were seen after the trauma occurred, but before the diagnosis was made. And in this group, the mean time to making the correct diagnosis was 7 days. Lots of other things were entertained, including viral gastro. Patients with head trauma present with vomiting. So also do patients with viral gastroenteritis. Accidental head trauma is another big one. And then I want to draw your attention about halfway down to apnea. There was a nice review looking at abusive head trauma in children who present with ALTE, and nearly 2% of them ended up having abusive head trauma. Half of those babies had an unremarkable physical exam in the emergency department. A little bit scary. We need to be thinking very carefully when patients present to us like this. So let's go back to Daniel. Remember that we said the big categories where things went wrong when we delay in child abuse diagnosis are in history taking, radiographic interpretation, signs and symptoms, the sentinel injury, adherence to guidelines, and reporting. Although we had gaps, and what we always say in the safety world is let's applaud what we do well, we did some things well. We did well on presentation, and we recognized the need for evaluation and mobilized both internal and external expertise to get the appropriate workup, including imaging, accomplished. Our imaging results were correct, which is not always the case. But then once the CPS closed their case, we let everything drop. We weren't as alert to sentinel injuries and the need for further evaluation when those occur. We failed to report unexplained injuries in a non-mobile baby, and we didn't adhere to thoughtful guidelines. Remember the AAP guideline from this spring. We had several missed opportunities to report injuries to our Children's Protective Services, and we're not alone. Honestly, these kinds of things happened all the time, but we could have done better, and hopefully all of us will do better the next time a child like Daniel presents to us needing protection from child abuse. Thank you very much.